This is a standard diagnostic model. It translates a patient's purely physiological state, like the expansion and contraction of these lungs, into discrete, trackable data. But this system has a strict boundary. It isolates the physical body, stripping away the external environment where the patient actually lives. To capture that external reality, medical coding uses a distinct ontological layer of data. On the left, we have the traditional diagnosis. What is physiologically wrong? On the right, we have Z-codes, the situational variables surrounding the patient. These external variables are social determinants of health, specific, non-medical factors that directly dictate health outcomes, categorized into social structures, environmental conditions, and access to care. Recording a diagnosis without this situational context generates a dangerous blind spot in public health data. Without Z-codes, the true reason for a patient's medical encounter remains completely invisible to the system. Look at this environment. When a severe disaster strikes, the immediate threat to a population is rarely a novel pathogen. The hazard is the collapse of the physical surroundings, which instantly redefines every patient's healthcare requirements. A snapped power pole or a tangled utility line cuts off electricity to entire blocks. For a patient relying on an oxygen concentrator or refrigerated insulin, this infrastructural failure turns a previously stable, managed condition into an acute medical emergency. In the immediate aftermath, the physician isn't treating a new physiological disease. They are treating the fallout of a hostile environment. To document these precise circumstances, medical coding relies on ICD-10-CM guideline B.19.d. This is the specific protocol for logging non-medical hazards. When the physical environment collapses, standardizing these disaster variables through guideline B.19.d is the only mechanism hospital networks have to preserve their data integrity and track exactly what their community is facing. Within a standard electronic health record, or EHR, this data has a specific location. The primary home for Z-codes is the reason for encounter field. This schematic illustrates how the reason for encounter field functions. It expands out to sort information into 3 distinct categories. The first column records social conditions, tracking variables like extreme poverty or complex family circumstances. The second column logs environmental issues, capturing immediate physical hazards like structural damage. The third column measures access to care, documenting logistical barriers like the unavailability of a local facility. By categorizing these variables, a chaotic, highly personal patient story becomes a series of concrete, trackable data points. Organizing a patient's reality into these 3 structural columns gives healthcare networks the metrics they need to anticipate widespread logistical shortages during an ongoing crisis. This image shows the reality of post-disaster triage. Physicians are working out of makeshift shelters, moving quickly from cot to cot. They do not have the time to author comprehensive clinical charts. Because formal patient histories will be incomplete, coders operate under a strict rule. They must utilize whatever fragmented documentation is available to extract the relevant context. Here is a simulated clinical note from a displaced patient. It is messy and brief, but buried in the text is a crucial phrase: homeless due to storm. A coder translates that directly into code Z59.0, standardizing the homelessness. Scanning further down the same fragmented chart reveals another critical detail. The patient requires ventilator. Power grid failed. That note maps perfectly to code Z99.12, documenting the ventilator dependence. By systematically mining limited documentation for these exact Z-codes, coders prevent critical environmental vulnerabilities from being erased from a patient's permanent medical history. Identifying the correct codes is the first step. They must be sequenced accurately within the database. This logic tree dictates code placement. We begin at the top with Z-code assignment. If we follow the left branch, the code is assigned as the principal diagnosis. A Z-code is only listed as principal when the external circumstance is the primary reason for the medical encounter, completely overriding any underlying physiological issues. Following the right branch, we assign the code as a secondary diagnosis. This is used when the circumstance is a complicating factor rather than the primary driver. When conflicts arise, always defer to the ICD-10-CM instructional notes to resolve the sequencing. To capture maximum detail, coders use stacking, applying multiple Z-codes to a single patient record. A comprehensive profile rarely relies on a single data point. It requires a diagnosis code, an external cost code, and multiple Z codes all functioning together. For example, a coder might stack code Z75.3, denoting an inaccessibility of healthcare, directly alongside code Z59.5, denoting extreme poverty. Stacking properly sequenced codes builds a multidimensional public health profile. It generates a level of demographic insight that a lone physiological diagnosis could never achieve. When coders fail to adhere to guideline B.19.d, it triggers systemic failures across the healthcare network. The first error is omitting Z codes. In pipeline A, a lone diagnosis code hits a dead end. The second error is incorrect sequencing. Forcing a Z code into the principal position creates a logic conflict. The system rejects it. The third error is ignoring social factors in fragmented notes. Contrast this with pipeline B, where properly stacked codes flow smoothly. Without this robust data, public health reporting skews off target, misallocating disaster relief funds. Administrative errors in this domain have high-stakes consequences. Inaccurate data degrades the intelligence a community relies on to mount an effective disaster response. To prevent these errors, the AMCI curriculum anchors its methodology with a specific concept, the MJ-GEM. The logic is binary and clear. The medical diagnosis tells the system exactly what is wrong. The Z code tells the system exactly why the patient is here. Effective coding requires capturing the entire situation. The condition and the context are equally vital parts of the patient's record. Rigorous Z code execution is the critical bridge. It is the only way to translate a patient's unseen struggle into the actionable data required to deliver systemic healthcare solutions.